नमस्ते बिटिया, हमेशा खुश रहो बिटिया। I am Dr. Bharat Sharma, Assistant Professor, Department of Pathology, Faculty of Homeopathic Science, Jyoti Vidyapeeth, Women's University, Jaipur. Today's topic is bronchiectasis. What we will learn about bronchiectasis: definition, etiology, pathophysiology, sign and symptom, investigation, and its treatment. Definition: bronchiectasis is defined as abnormal and irreversible dilatation of the bronchi and bronchioles greater than 2 millimeter in diameter, developing secondary to the inflammatory weakening of the bronchial wall and destruction of the elastic component of the bronchial wall. Here is normal bronchus, normal cell walls, and normal mucus. In cases of bronchiectasis, you can easily see damaged cell wall and also increased mucus formation. Bronchiectasis can be categorized as a chronic obstructive pulmonary disease manifested by airways that are inflamed and easily collapsible, resulting in airflow obstruction with shortness of breath, impaired clearness and of secretion, often with disabling cough, and occasionally hemoptysis. Severe cases can result in progressive impairment with respiratory failure. Now, etiology: primary infections, bronchial obstruction, aspiration, cystic fibrosis, primary ciliary dyskinesia, allergic bronchopulmonary aspergillosis, immunodeficiency state, deficiency of alpha 1 antitrypsin, and congenital anatomic defects. All can cause bronchiectasis. Congenital anatomic defects. William Campbell syndrome is a disease of the airway where cartilage in the bronchi is defective. It is form of congenital cystic bronchiectasis. This lead to the collapse of the airway and bronchiectasis. Now, Mounir-Kuhn syndrome is a rare disorder characterized by dilatation of trachea and segmental bronchi. Swyer-James syndrome likely is a development disturbance that leads to unilateral bronchiolitis, hyperinflation, and in some cases, bronchiectasis. Now, pathophysiology. The origin of inflammatory destructive process of bronchial valve is nearly always a result of two basic mechanisms. First is endobronchial obstruction, and second is infection. Endobronchial obstruction by foreign body, neoplastic growth, or enlarged lymph nodes causes resorption of air distal to the obstruction with consequent atelectasis and retention of secretions. Infection may be secondary to the local obstruction and impaired systemic defense mechanism, promoting bacterial growth or infection. May be a primary event, that is bronchiectasis developing in a suppurative necrotizing pneumonia. Here is a vicious circle of bronchiectasis. First, there is inflammation causing macrophage, leukophage, and neutrophilic infiltration, causing destruction, impaired mucociliary clearance, causing release of viscous DNA from dead cells, bacteria, leukocyte, destructive protease occur. Then it leads to the vicious lung secretion of mucus plug, caused to microbial colonization, Pseudomonas aspergillus, Staphylococcus aureus, Haemophilus influenza, etc., causing again inflammation, microbial, then again destruction, then a release of, and finally early death, core pulmonary, lung infection, and respiratory failure. Clinical features: cough with large quantity of mucus, sputum is foul smelling, fever, hemoptysis, crackles, and wheezing, which can be heard during the auscultation of lungs. Investigation: thin secretion HRCT scanning is the gold standard because has excellent sensitivity and specificity. CT provides further information on disease location, presence of mediastinal lesions, and the extent of segmental involvement. Chest X-ray increase in size and loss of definition of bronchovascular marking, crowding of bronchi, and loss of lung volume. Severe cases: honeycombing from tram track appearance, sputum culture, and bronchoscopy. Here is X-ray showing bronchiectasis. Here is a gross appearance of the lung called honeycomb lungs. Bronchoscopy video can be found on this link. Treatment: improving the airway drainage, expectorant bronchodilators and bronchoscopy. Third is postural drainage, antibiotics, and final is surgery. Postural drainage can be done in hospital settings by following. In case of anterior apical segmental or upper lobe. In case of posterior apical segment, this position is preferable. In anterior segmental lobe, this position is preferable. And in right posterior segment, left posterior segment, in right middle lobe. This session is powered by Digital Version 2.0, Jyoti Vidyapeeth Women's University. I hope you all enjoyed this session. If you have any query, please mention it in comment box. Thank you.